Thanks very much. It's an absolute pleasure to be here this afternoon. I have a few relevant disclosures for today. So I've been tasked to give you the GI perspective, and I'll be upfront. I'm a paediatric GI, so I'm going to be giving you the paediatric GI perspective. I'm also a clinician. I look after a clinic of about 1,000 kids with IBD. I have about 4 new diagnoses a week. I have about 450 patients on biologics, which are mostly AntiTnf, and about 2 or 3 new biologic starts a week. My catchment zone is about the size of Scotland. Besides that, I also run a number of data coordinating centres and 2 large inception cohorts, one through North America and one specifically here in Canada. So when we looked at our patient experience over the 80s and over the 90s, it was depressingly static, and depressingly 1 in 5 of our patients had chronically severely active disease despite our best therapy. And our best therapies in IBD are dual. We go for induction of remission and maintenance of remission. But walk on the moon, talk to Mars, our list of options is really very short. And until the 90s, it was essentially 5-ASA and steroids. We then moved into the immunomodulators for our maintenance options. And it wasn't really until the last 15 or so years that we've had the anti-TNF agents. And very, very recently, as in months to a year, we've had alternative biologics with the IL-23/12 and anti-integrin agents. So I'm going to concentrate on anti-TNF because that is where our biosimilar is, and this is where we are for biologics in GI. And why do we use it? We use it because, you're right, this really doesn't work well. We can turn that into that in 6 weeks, and never before have we ever been able to do anything like that in inflammatory bowel disease therapy. It's completely changed our treatment paradigm. We're becoming a little bit like a rheumatologist now, where we treat to target. And our targets have moved from just being happy to accept our patients feeling better to demanding the aspiration of mucosal healing. And why do we target it? Well, Crohn's we've always thought of as being a relapsing and remitting condition where the symptoms would come and go, and we would fool ourselves naively that we thought that meant the disease would come and go. And we have recently realised that it's just this progressive, increasing damage which is irreversible happening to the gut over time. And so we target mucosal healing because we believe in the long term. We believe we want to avoid the awful things, but we also want to make overall life better, and we would like to lower costs, both at a healthcare spending level, but at a personal utilities level, that we have our patients out there with the lives they're meant to lead being productive members of society. Now, using anti-TNF over 15 years, remembering this is the only biologic we have ever had, we've learnt a lot. To begin with, we gave it to you to get better, and it was fantastic. It worked really well. So it was an induction agent, our best induction agent ever. And then we realised that you got sick again because I cannot yet cure IBD. So then we gave it to you when you needed it. Whenever you got sick, we gave it to you, and we went into this period of what we called episodic maintenance. We rapidly realised that that period to using it became shorter and shorter, and very quickly these fantastic agents stopped working, and when they stopped forever. And suddenly GI had to become immunologists, and we had to remember back to that idea that continuous presentation of antigen gives you tolerance, and intermittent presentation of antigen gives you immune responsiveness, which neutralizes your drug. And so we went into the period of regular maintenance, where we deliberately, regularly gave these agents, we improved tolerance, we reduced the chance of developing neutralizing antibodies, and we markedly improved the durability of response to these one-off agents of change. And so in 2000 onwards, this is now our patient experience. We have about 2% of our patients who have chronically severely active disease, all through one agent of change and learning. I'd like to introduce to you KidsCan. KidsCan is our network we've put together of paediatric IBD centres from coast to coast in Canada, 14 different centres. All of them academic, because that is where paediatric IBD is, because that is where paediatric GI is. We're all in academic centres. When we started about 3 years ago, we had a quick survey to see where we're up to. And our Crohn's kids see minimal steroids and in general are in clinical remission or low activity. And it was no surprise that 60% of our kids with Crohn's are on an anti-TNF for their maintenance agent. This is how we achieve those outcomes. And so we have had a pattern of change in use. Not only do we treat to target, but we now encourage people to target their treatment. One of the first concepts was with the timing of when you would introduce this agent. And there's been this catchphrase, and GI loves catchphrases, top down versus step up. I think that's the most ridiculous concept because whoever goes down when you're at the top. So I prefer to call it with an Aussie concept, the king hit. And there is an Aussie colleague here, but for the rest of you, the Urban Dictionary will remind you that the king hit is the most hardcore, damage maximising, chronically solid punch that can be thrown. It sends the aggressor off balance if it doesn't actually hit the intended target, which is, I think, a perfect description of upfront use of anti-TNF in IBD. We've had the opportunity of looking at this approach within one of the cohorts that I run through North America. And we compared the use of standard immunomodulators stepping up quickly to when we needed it with great outcomes, 60% clinically disease-free without steroids. It's just not as good as 85% for a matched cohort, matched control. Relative risk change, 25%. Number needed to treat, 4. We have just recently published our ongoing primary outcomes for that, looking truly at damage, the irreversible changes, and found exactly the same thing, that early utilisation of anti-TNF within 3 months drastically changed the presentation of penetrating disease. The top dotted red line are those on anti-TNF, the bottom red line are those not. Marked difference in irreversible damage. So, no surprise when we start looking at our Canadian data that our Crohn's patients are starting therapy from new diagnosis. 16% of Canadian children start up front with an anti-TNF therapy because of what we know will happen. So the million-dollar question isn't, will this agent work? This is a ridiculously high response agent. The question is, will it continue to work? Because that is where the money is, durability of response. Early trial data showed us loss of response of 20–30% within 12 months. We're talking about a lifelong disease here. Secondary loss of response mostly being due to loss of tolerability, but we also noticed that higher drug levels were associated with better durability. So suddenly now GIs had to become pharmacologists as well. And we're simple men and women, we live by 2 rules. If you aren't there, you can't help, and if you keep coming and going, you're not going to be tolerated. And that is truly the pharmacokinetic knowledge of a GI. We've come over time to realise that there are an inordinate number of different factors which impact the kinetics of anti-TNF in IBD, such that all of these factors eventually come down to that irreversible position of sensitisation. But the processes prior are all very reversible. Now, a 20% annual loss of response, honestly, that would be devastating to me if this is what I was expecting from my patients. And so we looked at our practice at Sick Kids. We looked at our first decade of experience, 90% primary responders, just as advertised in the real world, 80% of them still responding at 5 years. We have a 4% loss of response. Most of those people lose response due to development of antibodies, but the kicker here, more than 1/3 of our patients get dose optimized within the first 12 months, i.e. we go outside of recipe and dosing to make sure that our durability is there. If you now look at real life data in the adults, this is a European cohort, and it's about there, 90%, 10% loss in your first run, and about 10% per year. So we're not in the real world looking at 20 or 30%, we're looking at about 10% in European adult context. Now, 1 dose for all. We're a very egalitarian community here in Canada. 1 dose for all in infliximab is 5 mg per kg, 3-dose induction, 026, and then Q8 weekly maintenance starting at week 14. This is what I want my fellows to tell me when I say you're about to prescribe anti-TNF therapy with infliximab. Now, we noticed that changes in dose altered our outcomes, and so we looked at what were the levels we were achieving through induction. And with standard recipe dosing, we found a median at the end of induction of around 10, 30% below 5, a significant number with very little drug at all at week 12. This is actually 2 weeks before you'd be expecting to get your first maintenance drug. And the kicker again here is the literature tells us we want to be at 5 at 14 weeks to have our best therapeutic outcome. So more than 30% on normal recipe dosing weren't even making our first time point. So across the network, we started prospectively looking at early monitoring to see what is this true variability across the country. And exactly the same findings across all centres and kids using recipe dosing. And importantly, when we look just prior to the third dose, so the week 6 dose, a huge variability in levels based on recipe dosing. We looked at the relationship that exists between 6 and 12, so second and third dosing, and showed that the early introduction of therapeutic monitoring could have a very positive impact on the optimization of therapy leading to improved durability. Another area that we noticed in IBD was ulcerative colitis never did as well. This, I keep saying, this is a Crohn's outcomes. Ulcerative colitis, they were really disappointing, and we were seeing rapid sensitization almost during induction by second or third doses. This led to an empiric practice change, this concept of intensified induction, which generally sort of meant 7 to 10 mg per kilo, dosing 0, 1 and 4 with sort of a maintenance of about every 4 weeks. Way off script. Nothing here is fundable as far as our regions go. So we looked at our local, I think I'm getting a flat battery, Dan. We looked at our local findings from this. And certainly, fantastic outcomes using this intensification. 26% difference. Number needed to treat, 4, bizarre. But it was disease-specific. In steroid-dependent UC, they remained with relatively poor outcomes no matter how much drug we gave them. And so maybe one size does not fit all for this sort of drug, and it is very different even within our indication of IBD. And so the therapeutic paradigm in Canadian GI is, number one, we select our initial therapies based on our estimation of disease outcome risk. We then have regular review of outcome, and if we are not meeting target, we have a change of therapy. And when we're into anti-TNF, we aim for dose optimization, looking through, trying to avoid that risk of exposure, re-exposure, which is what sets you up for the irreversible sensitization through monitoring of inflammatory load, monitoring of drug kinetics, optimizing adherence. In every other drug, not taking your drug just means you feel bad today. In anti-TNF and monoclonal antibodies, not taking your drug means it will never work again. You will sensitize. And being able to promptly respond, the moment you see where you are, to be able to implement a change in a timely fashion, or you lose that little window that you were going for. I think it's fair to say, and I will try and go back to that one because I thought it was cool, that Canadian GI, I think, are relatively sophisticated anti-TNF prescribers. And so what is our current Canadian environment? People who need the drug in Canada get the drug. We do not have problems accessing drugs here. We've got resources which facilitate timely therapy starts. We've got resources that facilitate early optimization of drug exposure, including access to drug. And we have resources which improve adherence. And I will be upfront, almost everything that we do to make this work is paid for by the pharmaceutical company. None of this comes from our provincial drug plans. So AbbVie have their own patient support, and they've got some cool data. This is their US data with fairly modest changes in adherence and persistence. They made a 20% difference in non-drug medical costs. If we look at the Canadian, just one part of their Canadian experience, which is coaching, the kid gets rung up or the patient gets rung up once a week to get you going. Fairly minimal changes in perseverance. By 3 years, 18% difference in adherence. Marked improvement, and importantly, 13% difference in clinical remission based on this relatively simple implication for improving adherence. So when we look at data for the biosimilars, the questions I think are pretty simple. Does it work? Is it going to keep working? Is it okay to switch? A lovely review came out just 2 months ago. These are our observational data. You can number them out, and some of them are repeated studies. I think a lovely comment that came from Vej on this was, the data suggests that immunogenicity, clinical outcomes are affected by previous use of the originator product. This is based on observational data. I think the Hungarian data is the best example. People who started the biosimilar naive, 60% remission at 12 months. Those who were switching over, 34% remission. Rubbish. This then leads into the whole thing of medical switch. These are the data. I point to you the fact sample sizes at best are double digits, occasionally triple digits, some single digits. I don't even know if that's a study. Power to detect change? Absolutely not. No observational data with enough power for you to say that that difference means that lack of difference is no difference. Duration at best 12 months, some of them publishing at 2 months, and only one with any specific data that can talk to us about immunogenicity, which is the be-all and end-all of monoclonals. Some really interesting things on observational data, and I highlight this, 72 and 60%. These are the remission rates they started with. And why would you be on a drug if only 3/4 of you are actually in remission? We have much better results here in Canada. The immunogenicity, again, is concerning. 12% drug formation after 14 weeks in someone who is established on this drug. That's rubbish. However, the variability between all of these observational studies says there's just a huge amount of confounding. I cannot honestly take usable data from the observational cohorts for application in Canada when there is so much confounding amongst the different European centres. So we have randomised data. We have the Northwich trial. We have to accept it will never be done again. There will never be more randomised data. And I have a few issues. People know I have more issues. But number one, the power is assuming 30% loss of response. I don't have 30% loss of response. I have 4%. At worst, adults have 10%. This is not powered adequately for IBD. And two, non-inferiority margin of 15%. This slide has changed care across the world. This slide has made every adult GI give everyone dual therapy with combination immunomodulator and anti-TNF. This slide has an effect size of 12%. I have an optics problem convincing my colleagues that a non-inferiority margin of 15% is adequate when I've changed your practice based on 12%. And so it has some problems, but it is what it is. At least most of them were Crohn's. And so we could take away that we're going to see something. And I have to admit, I'm a big protagonist. I believe biosimilars have equal efficacy. And I've taken nothing but angst from this study because, yes, overall it was about 3%, but Crohn's way up here at the top was rubbish. It was way over to the left-hand side. I really don't know what rheumatology expects over a year. I do not expect the people who remained on originator to have 22% loss. Most of the diseases had a nice tight margin, however. Very, very understandable. And concerningly, the Crohn's did not. Why? It just seemed to be an outlier in the entire study, and it was the biggest single subset of the whole study. So there are non-molecule physician concerns about biosimilars that we need to deal with. One, are the additional administrative requirements going to be there to start a drug, to change a drug, to review monitoring? This is all admin that is currently supported. Will there be access to the supports we currently have? Access to monitoring, access to more drug when you want to respond to your monitoring. Therapeutic drug monitoring, well, we have all of these levels. We've spent years and millions of dollars working out. Are they actually going to be exactly the same for a biosimilar? Do they need to use the same assay? Are assays interchangeable? The OAG has a statement, basically their statement, we don't believe in switching, we do believe in pharmacovigilance. And I just have a couple of comments, and you know what my comments are going to be on this. Appropriate monitoring, well, who on earth is going to pay for this? The testing, the distribution of results, the timely coordination. Everything for me at the moment is really quick, but my system does not pay for it directly. How should we be monitoring? Well, again, who's going to, I love the approach to biological monitoring. I think that is correct. But again, who is going to approach and pay and organise for this? Because this does not currently exist for us here in Canada. And the practicality of monitoring and observing, we still believe in this idea that infliximab is infliximab is infliximab, and if you really think that someone will record a batch number for me, good luck. Especially on a every 2 weeks adalimumab when that comes in 12 months. And so the Canadian biosimilar world from a GI perspective, markedly limited number of highly effective drugs over 15 years means that Canadian GIs are really sophisticated with the only agent they've had for 2 decades. We have an infliximab product that we are used to using. And it is more than just an anti-TNF molecule, and it's a wide-ranging package of tools and services. And together, that package has resulted in markedly improved durable healthcare states for the majority of our patients. And so to maintain patient-centered outcomes in their current levels, providers of biosimilars for anti-TNF inflammatory monoclonal antibodies are going to need to provide a product that is similar to the innovator and not just a molecule that's similar. And the future, just because you've got a new one doesn't mean it's going to substitute. Now that we're into biologics and fantastic responses, they're going to be a mix and match. A little bit of this, a little bit of that, better maintenance, better induction, a little bit of this just to get rid of that last 10% who aren't better. So there are going to be increasing costs. We need to have cost containment, but the way we're approaching it without reducing healthcare outcomes that we have already achieved is going to be important for us. Thank you.
Any direct, quick questions? That was a phenomenal amount of information. Thank you very much indeed. Any quick questions to Tom? Matters of fact, simple issues that we could clear up before we get into the main discussion. Yes, please.
You expect to get free drug from the biosimilar companies. Right now you're getting compassionate supply drug. In oncology, some of the biosimilars are talking about providing compassionate access to drugs as well. What's happening in Europe, and what do you expect in the market?
So this is why the Canadian perspective is so important. So what I just described is not the European experience. This is why the European drug sensitization rates are so rubbish. And this is why they sit with people with poor remission rates still on drug, because they were never able to adequately optimize. I work with mates in Scotland. I know what their accessibility is like, and so what they've now got is a fantastic improvement. As I'm saying, the package of AntiTnf working in Canada is all of those things. If a biosimilar does not provide that, our outcomes will not be the same.